Hi, good morning, dear students. In last class, we had discussed about the S inhibitors and ARBS. Pretty much all the detailed theory has been covered in that class. So today we are going to discuss about the practice questions. So these practice questions are going to serve two different and unique purposes. One purpose is to get the quick review and revision about the concepts that we have learned, and also you can get the practice. Okay, so this is a revision as well as the practice for the S inhibitors and ARBS. So we are going to discuss 20 different questions in today's session. Okay, so let's jump into it. Okay, so let's we start from the very basic question. What is the mechanism of action of ACE inhibitors? ACE, angiotensin converting enzyme. So what you have to learn is the physiology of the renin-angiotensin system. Renin, where renin is coming from, angiotensinogen is coming from which part of the body, and angiotensinogen convert to angiotensin 1, angiotensin 1 to angiotensin 2. This angiotensin 2 is binding to the receptor of angiotensin, and that also affect in three different areas. One is aldosterone, second is blood vessels, and also this angiotensin converting enzyme is responsible for bradykinin breakdown. Okay, so this bradykinin mediated functionality also you have to understand, because the lungs bradykinin concentration increase that can cause a dry cough, and also the bradykinin level is building up in the body that can cause the allergic reaction, and also angioedema, this kind of situations also associated with bradykinin levels. Aldosterone mediated effect that can cause, like aldosterone is responsible for what? Sodium and water retention and potassium excretion. But now the aldosterone concentration is deplete, that means the potassium is going to retain. So S inhibitors can cause the hyperkalemia. Okay, and another area is vasoconstriction. That's the function of angiotensin 2. So when we are blocking the angiotensin 2, they are going to cause the vasodilation. And the fourth most important mechanism of the S inhibitors are growth factor inhibition. Okay, that's the growth factor inhibition has two unique functionality. One is there's the cardiac muscles, especially the left ventricles overgrowth is minimized. That means S inhibitors are considered as a cardiac remodeling medication. And also the growth factor inhibition that might cause the myelosuppression. Okay, this myelosuppression can cause the pancytopenia, means all the blood cells concentration deplete, and that's why the erythropoietin dose need to be increased in some patients, those who are taking the S inhibitors. So that's the quick revision or review about the S inhibitors. But the mechanism of action is angiotensin 1 to angiotensin 2 conversion is block. Okay, which peptide is breakdown is also inhibited by the S inhibitors? Which peptide? Bradykinin. Name one S inhibitors that is indicated for diabetic nephropathy in type 1 diabetes. Captopril. Captopril has two important and unique things need to be remembered. One is a short half-life, multi-dose required. All other S inhibitors require single dose. Okay, once daily dosing frequency. And another important point is captopril has a sulfa moiety. Okay, what is the common side effect of S inhibitors? Not typically seen in ARBS. ARBS is mainly receptor blockers, and this is enzyme inhibitors. Okay, so bradykinin mediated side effects like dry cough is not associated with ARBS, but this is a common side effect of ACE inhibitors. Dry cough. Okay, what class of drugs are called sartans? Losartan and all other sartans are ARBS, angiotensin 2 receptor blockers. Okay, what is the adverse drug category of ACE inhibitors in ARBS? This is category D. That means we must not have to give this medication to the pregnant woman. Okay, which electrolyte imbalance is common with ACE inhibitors and ARBS? Which electrolyte? Potassium, because the potassium retention and sodium and water elimination. This is opposite to the aldosterone physiology, because ACE inhibitors and ARBS block the production of aldosterone. Okay. So, thus the hyperkalemia, potassium level increase. Which ARBS is used to reduce the progression of renal disease in type 2 diabetes with the proteinuria? Okay, irbesartan and losartan. These two medications. This kind of information you can find in the comparative information. Okay, in class we have discussed pretty much all the detailed concepts about the ACE inhibitors and ARBS, but mainly you have to look closely at the comparative information. In comparative information, we can find out the individual medications has a unique and special user cases. Okay, so irbesartan and losartan, these are used for the minimization of the proteinuria in renal disease. Okay, which type of angioedema is associated with ACE inhibitors? Bradykinin mediated angioedema. What is angioedema? This is also very common question you can expect in the exam. Angioedema, okay, swelling of the tongues, and due to that the breathing disturbance can occur. What is the key contraindication of ACE inhibitors? Pregnancy. Make sure pregnancy you must not have to give, because that inhibit the growth factor, and during the pregnancy growth factor is very important part. Okay, which ARBS is used? ARBS is used for post-MI when ACE inhibitors are not considered. Okay, so candesartan. So now you have three unique medications. One is candesartan is used for post-MI. The patient, those who have suffered myocardial infarction, after that, if we want a stabilization, we can start with the candesartan. And the renal failure patient or renal disease with the progression hasting proteinuria, we are using the irbesartan and losartan. So these medications are considered as the unique user case of the ARBS. Which drug class act at angiotensin 1 receptor? ARBS. That's the name itself indicating angiotensin receptor blockers. Okay, what adverse effect is less common with ARBS? Less common. Cough. Mainly which kind of cough? This is a dry cough. Okay, what renal condition can worse with the ACE inhibitors and ARBS? Which renal condition is worst? Renal artery stenosis. Okay, renal artery stenosis. That's why we are calling the bilateral renal stenosis. We must not have to give the ACE inhibitors. Why? Because the efferent and the efferent blood vessels is in a physiologically that is in a constricted form due to angiotensin 2. But when we are giving this kind of medications, ACE inhibitors and ARBS, this blood vessels become dilated. This dilated means that doesn't give opportunity to the fluid to stay at the glomerulus for the filtration, and because of that the filtration process not execute, and that can cause the renal damage. Okay, that's why the bilateral stenosis we must not have to give the ACE inhibitors in ARBS. So one is pregnancy, second is renal bilateral renal stenosis. What should be monitored within 1 to 2 weeks starting ACE inhibitors? Electrolyte functions, mainly the potassium levels, and also we have to monitor the renal function. Okay, which ACE inhibitor is used in acute myocardial infarction within 24 hours after becoming hemodynamically stable? Once the patient become hemodynamically stable, we have to start with lisinopril. Okay, post MI, lisinopril and candesartan, the another ARBS. If the patient is not tolerating lisinopril, we can start with candesartan. Okay, can ARBS be used in patient with history of ACE inhibitors induced angioedema? We can give, okay, but we have to monitor patient carefully because this angioedema is due to bradykinin concentration buildup. When the ARBS doesn't have a direct impact on the effect of bradykinin metabolism. Okay, which combinations should be avoided with ACE inhibitors and ARBS? Which kind of combinations need to be avoided? Potassium sparing diuretics and the potassium supplements. If we are giving potassium supplements along with ACE inhibitors, that increase the potassium level and the patient can get the severe hyperkalemia. That is the problem. Okay, so that's why we have to be very careful about it. Okay, good. Now, let's go to okay, name a common indication said by both ACE inhibitors and ARBS. Common indication, that's the hypertension. Mainly ACE inhibitors and ARBS used for the hypertension. Which ARBS is available in combination with the hydrochlorothiazide? Okay, all ARBS available in combination with hydrochlorothiazide except losartan. Okay, so these are the quick questions. If you are going to spend a good 15 to 20 minutes to learn the ACE inhibitors and ARBS, you are going to come out with lots of unique and very practically useful questions. These questions and these concepts can add more value in your learning process, not only for the examination, but that also for your real life practice. So when you are going to work as a pharmacist, all these information are going to make you rock star, because if you have a good confidence about handling this kind of questions in front of patients, so your confidence is going to be a skyrocket, and that can increase your relationship with your patients, and also that can give you the extra advantages. Okay, so thank you very much for a very short class, and see you in the next class. Have a great time. Bye bye, take care.